Welcome everybody to our TIF Talk Tuesday. I have the great pleasure of having Dr. Gilbert Simoni with us today. So Dr. Gilbert Simoni is an interventional gastroenterologist and natural orifice surgeon in Thousand Oaks, California. He's also the founder of both Advanced Gastroenterology Incorporated and the Advanced Digestive Center of Southern California. So welcome, Dr. Simoni, and thank you for being here with us tonight.
Thank you, Andrea, for that wonderful introduction, and thank you all for being here, everyone from across the country and the globe. And I really appreciate you giving some time to listen to our talk. And I also wanted to thank Endogastric Solutions for bringing this TIF Talk to everyone, and hopefully I can give you some pointers tonight and some questions. I appreciate that.
Wonderful. Yes, thank you very much, Dr. Simoni. And to everyone that's watching today, as you know, this is a live session, so we're very excited to have you here. If you have any questions at any time, please feel free to type them into the section. We'll try to answer as many questions as we can tonight. So again, thank you very much for being here. And Dr. Simoni, let's talk about GERD and the TIF procedure. Do you want to kind of explain to us a little bit about what is GERD?
Sure, absolutely. So first of all, in medicine, we have a lot of acronyms, so I have to apologize for that, but we have to deal with it. So GERD, it stands for gastroesophageal reflux disease, which is a condition that essentially notates an upsplashing or backwards movement of the contents of the stomach that can actually come up into the esophagus, irritate the esophagus, as well as the upper respiratory area, causing a myriad of different symptoms, some that are fairly easy to recognize, some that definitely needs an expert to rule those in or rule them out. I don't know if you can see this slide. Essentially, as we eat food, it goes down the food pipe. It passes a valve that essentially protects your esophagus from the contents of the stomach. This valve is also called lower esophageal sphincter, which is located at the gastroesophageal junction, or GEJ. And when that valve is incompetent or it doesn't work, contents of the stomach are pushed up into the esophagus, causing all kinds of symptoms and problems. So I want to just give you a slight bit of anatomy. This is an actual anatomy of the lower esophageal sphincter. It's got some intrinsic muscles. There's another muscle that's not shown out here. That's the diaphragm that forms an outer barrier to the gastroesophageal reflux disease. Essentially, this valve is situated between the esophagus and the stomach, and normally opens up when you eat food. Food goes in, then it closes and prevents the contents from coming back up while the stomach is churning the food and pushing it into the small intestine to the other way. These are endoscopic views of the valve from the top looking down this way, and this is an endoscopic image from inside the stomach looking backwards at the valve. As you can see, it's a nice tight valve in this particular situation, grabbing the scope, and even though we have insufflated the stomach quite a bit, you can see that this valve is staying nice and tight. So essentially what happens with gastroesophageal reflux disease is that this valve becomes ineffective, and it either becomes loose or you develop a large Hata hernia. As you can see, there's a huge gap here between the endoscope and the actual stomach. So this gap that you see here is a large Hata hernia, comparing this image to this one. Okay. Therefore, this allows the contents of the stomach to come up and cause certain symptoms. So we always talk about different types of symptoms. I mentioned earlier what are some of the gastroesophageal symptoms, and GERD typical GERD symptoms, everybody knows: reflux, heartburn, regurgitation, and so on. But atypical symptoms are the ones that are difficult to diagnose. And a lot of times patients go through multiple different doctors and take years for someone to finally realize that a lot of these symptoms could actually be related to gastroesophageal reflux disease. I hope that answered your question.
Yeah, no, that's very great. And thank you. I love the slides. It's nice to have a visual when we're doing this. So thank you. Talking about the typical and atypical, there's always a question of, do I go to my general practitioner? Do I see a gastroenterologist? Who do I see? Who do these patients need to talk to if they are having these types of symptoms to help them figure out what's the best treatment option for them?
Great question. And generally, it's always recommended for patients to do see their primary care physicians as they are what we call the captain of the ship. So there's a lot of different things that need to be taken a look at, especially, for instance, let's say somebody has chest pain. They definitely need to see their primary or maybe a cardiologist to make sure it's not heart disease that's causing their chest pain. You can't just right off the bat say that it's GERD.
Right.
That said, over the past couple of decades, the medications for reflux or GERD have been readily available. So many of the patients that I see, they have already self-diagnosed. They've gone through doing a lot of different things that we're going to talk about as to preventing GERD, and they end up taking medications and they self-diagnose. So if you have symptoms of GERD that either does not respond to medications or is refractory to medications, you definitely should see a gastroenterologist. Other symptoms that might also be present are what I call dyspepsia, or ill feeling in the stomach or abdominal pain. Those are not necessarily associated with GERD, but there are other conditions that can cause GERD. So those need to be also evaluated and addressed.
Okay. Thank you very much. So let's talk about managing GERD and treatment options. You kind of mentioned the over-the-counter PPIs. Do you want to talk a little bit more about different treatment options for GERD?
Absolutely. So before we jump into that, many patients already know about some of these before getting into medications and all that. A lot of people do read. There are certain things that you have to avoid, like chocolate, peppermint, citrus. I'm sure many of the patients who have experienced GERD have already done these. Once, and this is not a very effective treatment, unfortunately, or avoidance for GERD, especially somebody who has a mechanical problem, such as having an incompetent valve. Once this is not working, a lot of times patients start using medications. Mm-hmm. And the most common or rudimentary anti-GERD medications are antacids, which essentially neutralize the acid of the stomach. Then there are H2 blockers, such as Pepcid, Tagamet, and we also have Zantac here, which has been taken off the market. And the latest and supposedly greatest medications are proton pump inhibitors, or what we call PPIs. So all of these medications do provide some symptomatic relief. The issue with them is that none of them actually fix the underlying problem, which the underlying problem is not increased acid production. All right. There's a lot of misinformation and misunderstanding that if somebody has GERD, they have too much reflux, too much acid in their stomach. That's absolutely not true. The main reason is that the contents of the stomach come up, and all these drugs do, basically, they just mask the symptoms.
Okay. Great. Thank you very much for that. So, so PPIs is always a big question as to, are they safe? How long should I take them? Do you want to talk a little bit more about PPIs and potential long-term side effects of long-term PPI use?
Absolutely. So one thing that we truly need to understand before we kind of understand why PPIs are not great. Well, they're good for taking care of symptoms, but in long term, they're not that great of a drug. We have many different studies that have shown some of the side effects, especially long-term use of PPIs. But before we get into that, one thing we have to understand is that the stomach acid has many different functions that is absolutely necessary for digestion of the food, prevention of infections, liberation of things from the food in order for you to absorb certain minerals such as calcium and iron from your food. So when you take PPIs, and PPIs essentially, they shut down the factories that produce acid in your stomach. So you basically have, you produce no acid in the stomach.
Right.
When you do that, you affect all these other processes that are dependent on the stomach acid. Therefore, you come across all these different problems that have surfaced, and it's no surprise that we have many different studies for at least osteoporosis. There are a lot of patients who've been on long-term use of PPIs, and they develop iron deficiency anemia, B12 deficiency. There's increased chance of infections such as C. diff. And there's some notion now that we have this COVID-19 pandemic. There is some notions that COVID actually can present in the GI tract, and it can actually go through the stomach and end up in the small intestine and colon. And in my opinion, a lot of those patients that have GI COVID most likely are on PPIs. I don't think we have any, or unfortunately, we don't have any data on that, but I suspect that that might be one of the reasons why COVID-19 might be increase in patients that do take PPIs. Then there are a couple of other things, microscopic colitis, and there's been some questions about Alzheimer's. I do have a lot of patients that come in who feel they're starting to become forgetful, and they've been on PPIs and they really don't want to be on it. There are controversial studies, but nonetheless there are problems with taking these PPIs long term. And long term by FDA is, by the way, mentioned as more than 2 weeks. So if you're taking PPIs for more than 2 weeks and you're still having issues, I definitely suggest see a gastroenterologist.
Yeah, that's a really good point. Thank you for pointing that out.
Mm-hmm.
Do you want to talk about that next slide? I think that kind of...
Yeah, so that's a thing that this is a slide that oftentimes, unfortunately, goes. It doesn't get a lot of press because esophageal cancer is not, unfortunately, on a lot of physicians' radar. However, as you can see, many cancers who initially had a significant rise, they started to plateau off once we had screening for esophageal cancer, for those cancers, sorry. For esophageal cancer, unfortunately, we do not have a screening, and GERD, if it's not evaluated, can end up with causing esophageal cancer. I'm not insinuating that anybody with GERD is going to develop esophageal cancer, but anyone who does have chronic GERD should at least be evaluated at least once to make sure that they don't have any complications of GERD. And thanks for letting me talk about that slide.
No, I appreciate that. Can you talk a little bit about Barrett's? We get a lot of questions about Barrett's. And talk maybe the progression of GERD, Barrett's, esophageal cancer. What does that look like? And
absolutely.
Yeah.
So in order to understand esophageal cancer and Barrett's, we have to understand what happens with the contents of the stomach normally. So the contents of the stomach are acidic. As they are churned and then pushed into the small intestine, the small intestinal lining can withstand the acid. Therefore, it's a specialized type of mucosa or lining. When the acid of the stomach and bile and the contents come up the wrong way into the esophagus, because of this chronic inflammation, the esophageal lining tries to mimic the lining of the intestine. We also call it intestinal metaplasia. That means metamorphosis into intestinal lining. This change is called Barrett's esophagus. So intestinal metaplasia is Barrett's esophagus. This condition, Barrett's esophagus, has been notioned or known as the beginning of causing esophageal cancer. So if someone has chronic reflux, they could potentially develop Barrett's. If Barrett's goes undiagnosed, it can progress into esophageal cancer. And what the problem with esophageal cancer is that oftentimes it's found at a late stage. When someone has esophageal cancer, at the time of diagnosis, they're unfortunately stage 3 or 4, and unfortunately the life expectancy at that point is about 3 to 6 months. So it's a pretty serious issue that should not really be overlooked.
Yeah, I agree with you. We actually had a colleague that worked for our company that passed away with esophageal cancer. So
sorry.
I thank you. I appreciate that. But it's very dear to our heart, and obviously the more we educate people, the better it is, right?
Absolutely.
We just got to have everybody be advocates for their own healthcare, if you will. We do have a couple of questions. I'm going to ask some of them.
Sure.
I know we're not done with the presentation, but I just want to make sure we get some of these questions answered.
Absolutely.
I have a question from someone that says, my GI doctor says that if medicine does not work for acid reflux, TIF is not going to work. Is that true?
I don't know who told them that, but that's absolutely erroneous. There's been numerous studies that have shown that even patients who have had even difficulty swallowing or problems that are not truly GERD related, they actually responded to TIF, even those that didn't respond to proton pump inhibitors. I have no idea where they get the data from, but it's definitely, I don't think there is any scientific evidence behind their claim.
Perfect. Wonderful. One more question and then we'll continue.
Sure.
How many TIF procedures have you performed and what is your success rate?
Honestly, I have no idea how many. Hundreds.
We can probably tell you.
Yeah, you guys have my data more than I do, but it's been hundreds. Yeah. I started in 2009, and since then, more. I would say, I venture to say that more than 95% of my patients are extremely happy with the TIF procedure, and they've not needed to be on any drugs, and almost, I would say maybe about less than 1% of them needed to have it retightened for various reasons. But generally more than 90, I would say at the very least, more than 95% success.
Wonderful. Thank you. So let's go ahead and start talking about the TIF procedure. I know you've got some slides and also an animation that you wanted to share with us.
Sure. So, yeah.
Yep.
Yeah, no problem. So before I get into that, I just wanted to show you what are some of the things that a lot of patients that come to me say when they want to have the TIF procedure done. I have to tell you that unfortunately, I'm probably one of the end physician that patients see. Typically, patient starts seeing their primary care physician, they're put on PPIs, and let's say they have sinusitis or they have cough or chronic cough, and they see a pulmonologist and they see a cardiologist, they see a ear, nose, and throat doctor. They go through all kinds of different things, and they finally get to me and they're like, you know what? I wish I would feel normal again. I'm tired of seeing all these doctors taking all these drugs, antibiotics, PPIs, H2 blockers, I have to sleep essentially upright all night. I'm tired of doing that. So these are some of the actual things that patients have said. And if you or anyone you know is in this category of quotes, please see someone. Call me, call one of my colleagues who actually do TIF procedure and understand GERD, and get yourself checked out so we can help you and hopefully bring you back to a normal life.
Right.
Now, as far as the TIF goes, TIF stands for transoral, means through the mouth, incisionless, meaning without cutting, fundoplication. And fundoplication is where you take the fundus of the stomach and you try to recreate the shape of the valve. One of the original treatments that was there is called Nissen fundoplication, whereby they essentially go in and they cut through your stomach, get into the bottom of the diaphragm, they suture that, and then they come through and they grab fundus of the stomach, which is the top of the stomach, and they wrap it around and suture it onto the esophagus. It's a, I don't want to step on any toes, but it could be a pretty barbaric procedure. What we have done, we have essentially taken the essentials of a Nissen fundoplication, and we have come up with a way to recreate the valve to its original form without disrupting all this anatomy of the stomach and the esophagus. And the most dreaded thing in Nissen is when somebody actually affects the vagus nerve, which is the main nerve that controls all the digestive tract. The other thing that can happen also, a lot of times patients end up with this big gash, although this is a post-op Nissen patient. This is becoming less and less, but still, it is a pretty major surgery. So what we do with TIF, I'm going to bring this down, and show you some animation as to what we exactly do. But before I do that, this is a kind of cartoon of what we do with the TIF procedure. So this is the device which essentially goes through the esophagus, and we grab the loose tissue where the lower esophageal sphincter is supposed to be, and we kind of pull it into this plastic, what we call a tissue mold, and we wrap this loose tissue around. We put some sutures in there. As you can see, these little blue things are H fasteners. They're very tiny. Here, they look huge. They're a lot smaller than this. And we essentially create a wrap around of this loose tissue, and we recreate a normal valve. As I showed you earlier, this is a large Hata Hernia that was one of my patients that we recreated her valve. And if you notice here, this valve looks almost exactly like a normal valve is supposed to look. So there are lots of benefits as to why we do TIF procedure as opposed to other surgeries. It is the most compatible surgical intervention with real life valve. What that means is that most other surgeries are done when the stomach is desinflated, or they take out the air from the stomach. A normal person's stomach is not deflated. You always have fluid, gas, food, bile, acid, all kinds of stuff in your stomach. When we do the TIF procedure, we actually expand the stomach to its maximum volume, and then we wrap the lower esophageal sphincter and recreate the valve. That way, it comes out to be almost exactly like a normal valve. So that's one of the main things that TIF can offer. Aside from that, it's non-invasive. You don't have to stay in the hospital. It's usually we do it early in the morning and you go home within a few hours. And also there is less pain, less discomfort, less chance of infections. Any way you look at it, it surpasses in many different ways over any other surgical procedure, at least in my opinion, and it's been shown by data.
Wonderful. Wonderful. Thank you for sharing that. Do we want to show the animation?
Yeah, go for it.
Okay. Let's see. You want to walk through the animation while we're showing it? Let me. 1 second while we get that queued up. So while we're queuing that up, I do have a question.
Sure.
A couple of questions that have come up. So, the animation's on now. Do you want to talk through the animation?
One thing I wanted to also mention is that the side effects of other surgical interventions. TIF honestly has, when patients ask me, come to my office and say, well, what is the worst thing that can happen with the TIF? And I really have to think about it because honestly, most patients have minimal symptoms, if any, maybe a little bit of sore throat and some difficulty swallowing the first couple of days.
Sure.
Conversely, with other surgeries, especially Nissen fundoplication, most patients have long-term problems. They have issues with not being able to belch, not being able to vomit, having difficulty swallowing most of the time, and also there's a higher chance of Nissen fundoplication falling apart as opposed to TIF. So as far as side effect,
right.
TIF is a lot safer than any other surgical procedure that we have for reflux.
Fantastic. Yeah, thank you for bringing that up as well.
Absolutely, yeah.
So I think we did show the first animation. Do we have two animations, Dr. Simoni? I couldn't remember.
Subjective diagnostic
so the
measurements.
first
The
animation
TIF procedure
basically
has an
showed how
exemplary
we
safety
actually
profile and
recreate the
avoids
valve.
uncomfortable
The second
long-term side
animation
effects
just shows you what
associated with traditional
a post-TIF valve looks like, and it essentially looks like the image that I showed you earlier, the cartoons.
Okay, fantastic. Well, so the animations are done, but we're going to go ahead and answer some questions that we received from our viewers, if you don't mind. And then kind of want to talk a little bit about what the recovery looks like and what happens after the fact. But let's answer a couple of questions. We've got a question from Carlos. He says, I'm 27 years old. My symptoms are predominantly at night. I wake up 2 to 3 times per night. I'm taking omeprazole 40 milligrams daily for 14 weeks now. The head of my bed is raised, but I still wake up with a sore throat. This has been happening for like 2 months now, despite diet and medication. Could this be a sign that I might need surgery? I was told I had a hiatal hernia 4 years ago, but it wasn't that bad.
Oh my God, that's such a typical presentation. It's almost like patients as I see almost every day. So yes, I think with what you're describing, you're definitely refractory to medical treatment for gastroesophageal reflux disease. So Carlos has already gone through the lifestyle changes. He's done everything that he could possibly do. The medications do not help. And I think he's at a point that he really needs to find a permanent solution to his problem. Unfortunately, I hear this all the time where a patient had an endoscopy or they had some imaging study and someone told them, oh, you have a hiatal hernia, but it's not a big deal. Well, it depends. I've seen patients come into my office who were told you have a small hiatal hernia, and we do an endoscopy and find that they actually have a large Hata hernia or something above 5 centimeters. Scientifically and medically, I don't like calling them small, large, or medium. We need actual scientific data. I need to find out, what the size of the Hata hernia is, so we can help the patient best. But I think at this point in time, especially if you have a Hata hernia, you need to fix the valve. Otherwise, medications don't help. And one of the reasons why this, cough or clearing of the throat doesn't get help, because it's not because of the acid. You're basically getting rid of the acid, but all the other contents are coming up.
Right. You talked a lot about he has a question about the hiatal hernia. Can you talk a little bit about what can it be combined? There's always a question. I have a hiatal hernia, and can I get both? Can I get that fixed with the TIF? So maybe you can discuss that a little bit.
Absolutely. So I usually give my patients a slight visual. I kind of tell them that your esophagus goes through a small hole in the diaphragm, about 2 centimeters. This is a little bigger, but it's about 2 centimeters. When that defect, which we are born with, when that defect enlarges for various reasons, it could be because of gaining weight, pregnancy, putting too much pressure on the abdomen, lifting heavy stuff, for whatever reason, or sometimes it could just be a progression from a congenital issue. Then the stomach and the valve, they protrude into the chest because there's a negative pressure in the chest. That's how we inhale air. So when that happens, when someone has a Hata hernia, essentially your chest cavity is sucking on the stomach and esophagus and pulling it up. The question is going to be, how does TIF help this? Now, if you have a small Hata hernia, less than 2 centimeters, we can actually reduce that during the TIF procedure. If someone has a larger than a 2 centimeter Hata hernia, then we require to have what we call crural repair or Hata hernia repair, where one of our surgical colleagues goes in laparoscopically, they suture the diaphragm, and then I go in and I recreate the valve or do a TIF for them. That's also called concomitant Hata hernia surgery plus TIF. And about 60% of my patients get concomitant Hata hernia plus TIF. And to be honest with you, we really don't put a maximum size of Hata hernia on it. I've operated on patients with 8 or 9 centimeter Hata hernias. I've operated on patients with 3 centimeter Hata hernia. So they all do really well.
Fantastic. Thank you very much for that.
Sure.
Let's ask one more question, then we'll kind of go over post-op recovery type questions. So Din has a question. I had an endoscopy 2 weeks ago, and they said everything looks fine, waiting on pathology tests to come back, but I've been having all the GERD symptoms. So why is it that the doctors didn't see anything wrong?
That's an excellent question. I love that question. So patients that start with gastroesophageal reflux disease don't necessarily always have a Hata hernia, or they don't just go from normal, all of a sudden they have a wide open Hata hernia. There's a progression of the disease. And reflux or gastroesophageal reflux disease doesn't occur overnight. Things don't just change like that. There are minute changes or differences that start at the beginning of someone's initiation of their symptoms, and we call that an incompetent gastroesophageal reflux disease. Unfortunately, some of my colleagues don't spend the time to really interrogate the lower esophageal sphincter. You really have to insufflate the stomach and see how the valve responds to increased pressure in the stomach. There's also such a thing called NERD, or non-erosive gastroesophageal reflux disease, whereby patients don't really have any signs per se on endoscopy. They don't look like they have ulcers or irritation, but nonetheless, they do have reflux. And the only way you can find that out is by doing a pH study or impedance to find out whether things are coming up. So that's an excellent question. You definitely need to have an evaluation by someone who's a GERD expert.
Perfect. Wonderful. Thank you.
Absolutely.
So let's talk a little bit about your post-op TIF procedures. What's the diet look like? I know a lot of patients always say, "Oh, I heard the diet's really bad," or "Am I going to be able to do this?" Maybe talk a little bit about. You said hospital stay is very minimal, right? And depending if they have the concomitant procedure or not, but what's the typical post-op kind of recovery that you do for your patients?
Absolutely. Honestly, when we do the concomitant surgery with TIF, it doesn't really increase the stay much longer than just the TIF by itself. It might be a little bit more discomfort at the incision side where they do the Hata Hernia. Nonetheless, yes, the post-TIF diet is the most dreaded part of talking to patients about doing the TIF procedure, but we make it really easy as to what they really need to do. It's easy to say, oh, you cannot have this and that. So in order to understand the diet, you have to understand that we are manipulating your body's tissue. We're taking the tissue, wrapping it around, and suturing it. Therefore, there is a bit of inflammation in that area. So what we want to make sure is that we don't put too much pressure on the area that we have just fixed. Therefore, we start slowly. So we start with liquids the first few days. Then we, every week or so, we kind of advance the diet slowly until we get to a more solid foods. Most patients do well within 4 weeks or so. By week 4, patients can eat fish, chicken, pasta, soft eggs. However, we normally recommend for patients to be careful about what they're eating, especially not eating large amounts of food or too big of a piece of food, because it takes normally about 6 weeks for surgical wounds to heal. So that's why we usually recommend to be careful for about 6 weeks. But we have a very simple. It's a one-sheet paper that basically tells patient what they can eat, and we give that to every patient. And you can see it on my website. I have all these information on my website as well.
What is your website so people that are
yeah, sure, www.agimedical.com.
Fantastic. Wonderful. So are there any activities that they have to stay away from after the procedure, even aside from just the food?
Yes. Yeah. So anything that puts pressure on the diaphragm, we recommend to stay away from, such as lifting, pushing, picking up heavy stuff, anything that puts essentially pressure on your abdomen and your chest. So the first 3 weeks we recommend not to lift anything above 5 pounds.
Okay.
The last 3 weeks we recommend not to lift anything above 15 pounds. And however, patients can walk, although I don't recommend walking your dog, especially if you have a large dog.
Yeah.
I do. And also by, I think, week 4 or 5, patients can also start maybe swimming a little bit. The most notorious thing that I recommend patients not to do is not fly if they can, fly for about 6 weeks, because it's very difficult to fly somewhere and you don't even have a carry-on. So most carry-ons are more than 10, 15 pounds. So it's a good idea to avoid that if possible.
That's a good point. What if someone flies to come see you to have the procedure? Will they be able to fly back? If they have someone with them.
I recommend. I've had patients coming from Australia and Alaska. Generally, they stay with a friend. The recommendation for those patients is that they really need to, if they want to go back, they have to send their luggage beforehand.
Yeah.
So that they don't have to carry it, and I will allow them to fly back within 3 to 4 weeks.
Oh, that's
depending
good.
on how well they're doing.
Never thought about that. That makes sense. Wonderful. Okay, so we've got a couple more questions, so hope you're okay with that.
Absolutely.
Try and get as many questions answered today. So Valerie, Valerie says, how many fasteners are typically used during the TIF procedure? Is there any benefit to using more than the recommended amount for some patients? Good question.
It's a great question. It's a technical question, and we, at the very least, we use 20 fasteners. However, it depends on how the valve looks and how much of a loose tissue you have in that area. You may use more than 24 to 28 fasteners. In my opinion, just the number of fasteners don't necessarily translate into a better outcome. It has to do with what the post fundoplication valve looks like. Sometimes, using 20 just recreates a normal looking lower esophageal sphincter. Right. Sometimes 22 is still a little loose, and we kind of look around and see where the areas of defect is, and we put more fasteners in there. Arbitrarily using 30, 40 fasteners does not necessarily make things any better.
Wonderful, thank you. So another question, Tara asks, does GERD cause any tooth decay or cavities? My husband has GERD and has been to the dentist a lot to get crowns on his molars.
Absolutely. One of the major referrals to my practice are actually dentists who do see patients who have tooth decays and what we call dental erosions. There are lots of patients who have excellent oral hygiene, and they brush and floss and see their dentist on a regular basis, but they end up having all these erosions, which looks like you haven't been taking care of your teeth. So a lot of dentists are aware of that, and unfortunately, they do refer patients to have their reflux taken care of.
That's right.
Great question.
Yeah, that is a really great question, and I'm glad to hear you say that a lot of dentists recognize that. That's another thing that we need to make sure we try to educate dentists as well, and ENTs, because it affects other things than just the
That's absolutely true.
Yeah. Well, here's a good question, or funny. You live in California. What do you think about medical marijuana to treat GERD?
I don't think that's a great way to take care of reflux. It's a little bit off topic here, but what I have seen, and a lot of my colleagues have seen, we have some data to support this. There is something called cannabis-induced gastroparesis, which means that using cannabis causes the stomach to slow down, and you get what, in lay terms is called lazy stomach. So if you continue to, so cannabis initially might help because it speeds up stomach's emptying, but in long term, it will actually cause the stomach to become lazier and lazier, and you need more and more cannabis to have the same effect. Therefore, it actually increases chance of gastroesophageal reflux disease. So I personally would not recommend cannabis as a treatment of gastroesophageal reflux.
Okay, thank you.
Absolutely.
So Brad asks, how do I phase off my PPIs?
Excellent question. That's a very, very good question. Thank you for asking that.
Yeah.
So now, a lot of times I see patients who are not taking PPIs correctly. First of all, PPIs, aside from the latest one, which is called Dexlan, they all need to be taken on an empty stomach in order to get activated. If you don't take it on an empty stomach, you're not taking it correctly, so it won't work. If you are taking it correctly and you want to phase out proton pump inhibitors, the best way to do it is to taper it off. And what I tell patients, depending on how long they've been on it, if somebody's been more than a year on it, I have them take it one every other day for 2 weeks, and then one every 2 days for another 2 weeks, and then get off of it.
Okay. Yeah, that is a really good question.
Yeah.
Well, wonderful. That's, I believe, all the questions we have so far. We usually get questions after, but we'll try to answer as many as we can after the fact. But I do want to just bring up one other question, one other topic, if you will, before we close tonight. Obviously, we're in this kind of weird situation, this pandemic, the big elephant in the room, COVID. What are you guys doing? You know, a lot of patients, they're feeling all of these symptoms, they're having GERD. What are you guys doing at your location to make patients feel comfortable, let them know, you know, it's safe to come into our practice to get seen? Are you doing telehealth? Are you, just what types of precautions are you doing? Yeah.
We're taking a lot of different precautions. So things have changed from where we used to do practice. Right now, we schedule patients on a lot of times to make sure that we do not have more than 5 to 6 people in the office at a time. We test patients' temperature before they come in. Everybody wears a mask. My office staff are all tested for COVID, and we have these really great, we call P100 face masks that, you know, it looks like a space suit, especially when I have to do procedures. So we take a lot of precautions. We also, for scheduling patients for procedures, we do a COVID test within a few days of the procedure, and we ask them to quarantine themselves until the actual procedure takes place. And I've been back in doing procedures since late May, and we've had absolutely no problem since. Patients are very comfortable, especially since I actually do procedures as outpatient. Patients don't necessarily need to have to go to the hospital. They come to my center, which is right in my office, and we can that way we can control exactly who comes in and goes out. Okay. And that's another layer of protection for the patient. So they feel a lot more comfortable doing that as opposed to going to a major center or a big hospital.
Right. Wonderful. Well, thank you again, Dr. Simoni. Are there any last anything else you'd like to share with our viewers, or any last comments about GERD, your practice, the TIF procedure, anything else before we close?
Yeah, just a quick thing. You know, we do telemedicine. We also have actually a text message service. You can just text message us anytime, and we'll respond within hours, if not within 24 hours. And I think that's on top. Also, you can go if you can also go to gerdhelp.com. That's GERD help, HELP.com. There's tons of information on there, and if you're not in this area, you can find physicians that are just like me, and they can provide the same type of service for you through that website. You can also go on my website, www.agimedical.com, or you can call me. The only other thing I wanted to mention, which I didn't get a chance to talk about, is some of the challenges that we have in treatment of GERD, and that's I feel somewhat responsible because we need to educate other physicians in the community who do not still know much about the TIF procedure. I think that's of all the things, insurance and COVID and all that stuff. I think that's a bigger challenge than anything else, is educating my colleagues.
Wonderful. Thank you very much. Very well said. You stole part of my speech about GERDhelp.com. So thank you for that. No, you know what? I'm glad you did. Thank you. And to your point, you're right. Not only is it important for us to educate potential patients about GERD and the treatment options, it's also so very important to make sure that we're educating the clinical group, if you will. So, and we're doing our best today, I think, is one of the great ways to get the word out, to talk about it. And I appreciate you, and I know that these patients appreciate hearing from a real live doctor, telling them, answering their questions, and letting them know, what they can do for their GERD symptoms. So again, Dr. Simoni, I can't thank you enough for being here tonight and doing this and sharing your expertise with us. And if, as Dr. Simoni said, if you're in the Thousand Oaks area in California, please feel free to give him a call and or go to his website. And then also we have GERDhelp.com. We are here every Tuesday night, so please feel free to join us again for our next TIF Talk Tuesday. Have a great evening, and please stay safe, everybody. Have a good night.
Thank you very much. Take care.